Hello, my dear candidates. How are you all? I'm hoping all are fine and doing practice as well. And I'm seeing, mashallah, the performance is good today. The revision done DHA exam and mashallah, a very nice feedback. Hoping soon I'll get a nice feedback also. So it's my actually pleasure when I get nice feedback, and I feel so great that yes, my candidates are doing great. So today my third gynecology session, the third gynecology session makes I will practice today more question, okay? Because this question all are exam collection. First, second is that same question you will face in the exam, and you have to assess what you have to do and how you have to manage. Okay. So abortion, even my dear candidates, you know all that abortion is the topics you must face a question in the exam. Either even many candidates face two questions. So these are the topics we have to very confident regarding the abortion topics. So what we have to know, my clue tips for the abortion question is that first of all I want to ensure everything that my voice is clear, my dear candidates. Just want to be sure.
Yes, ma'am.
Yes, ma'am.
Okay. Thank you. So abortion topics, my dear candidates, it is said that loss of pregnancy before 20 week of gestation. Okay. So first of all, it is complete type, incomplete type, inevitable type, and misthreatened. Commonly exam, either they come in my exam, even I faced two, inevitable and incomplete, but inevitable was so complicated and long scenario, it was tough that of what is going on. So actually I highlighted 2 to 3 points. What are that? For the complete abortion is what? Full product of conception passed out. Okay, passes full product, and they'll tell that completely passes of product of conception. This is the one point. Another point is after passing product of conception, service will be closed because complete abortion. One recall maybe had or MOH, one recall, one of my candidate that said, ma'am, passes of product consumption fully, but they said service open. Actually, it is a point, though service close in strong point, but when they said passes of product completely and service open, these are the against towards the sentence because service must be close, but the mean is that just now basis of product of conception still service didn't close. That is the scenario some candidates face. That's why I said always remember 2 points: service close, but don't emphasize on cervical condition. It could be close, it could be because your scenario, your presentation, they give just now patient passes full product on consumption and still service dilated. So don't be confused. So this way we have to remember. So ultrasonography finding that usually don't give and follow up in OPD. Okay. So there is no need of DNC. Second point regarding the incomplete. Service never will be the closed. But as I said, cervical point never give emphasize. Cause my point of view, passes of some product or incomplete product, what they said, the complete, incomplete, okay? Cervical product on conception. So even though cervix will be dilated commonly, common is common. So these are the highlighted, common is common. If it is closed, it's okay. That after passing incompletely protocols, it closed down. But eventually the patient come to my hospital with dilated cervix, just incompletely passes of product conception. So it could be. Even it could be the close because patient come delay. So whatever the presentation, I have to more emphasize all point what they are telling. Some product of conception, if we do ultrasound, this finding they will not give. We have to remember the management strongly. Okay, if below 13 week of gestation, see expected management up to 8 weeks. If the pregnancy has not, so 8 week passed, pregnancy has not passed in a reasonable time, pregnancy has not passed in a reasonable time, or if bleeding, infection, other complication develop, managed by medical or surgery like DNC. Okay, so medical management, what? like two differential medication. You can give mifeprostone followed by misoprostol for the passes of the product fully, or DNC we can do up to 20 weeks of gestation. Just remember these 2 points. So inevitable, very important exam question for my MOH heart candidates. Still now for DHA they commonly ask from the complete, incomplete or threatened. For MOH heart candidates or SLE candidates can emphasis on inhibitable and missed, because these are the recall. Though all we have to know, but I am emphasizing those points. Inevitable means service will be the dilated, bleeding will be there, no passes of product of conception. So what it does it mean? Service dilated, but product of conception is not passes. But we can't continue this pregnancy. Though passage of product of conception didn't passes, but the viability of product conception though present. Fetal activity may be present, may not be present, but the thing is that this inevitable abortion or inevitable child pregnancy loss, we can't continue like threatened abortion, complete bed rest, we can continue, but inevitable abortion, though service dilated, bleeding only, even though there is no passage of concept, just remember inevitable abortion or inevitable type, we have to remember fetal activity may be present, but actually we can't continue. We need to do DNC. That's it. Okay, this is the point. And missed abortion. Missed always what? Missed means 2 types. No bleeding, but cervix closed, fetus is dead in uterine cavity, and we have to do this DNC. So first of all, my dear candidates, inhibited and missed, those are very important. First of all, we can't continue the pregnancy, but threatened, cervix closed, bleeding, okay, fine, but product of conception present, fetal activity present. If we strictly say physical activity resume, strict bed control, bed rest, so it's a we can continue. So this way we have to remember strongly. So before question practice, one point I want to discuss: fetal demise or stillbirth. So delivery of fetus showing no signs. So see, delivered a baby but no sign of fetal heartbeat. Okay, absence of fetal breathing, heartbeat. So it's a stillbirth. Another point we have to remember that for the stillbirth, fetal death at 20 week or greater of gestation. So 20 week or greater of gestation, fetal death. So equal to 350 grams. Just remember, after delivery of the baby, if there's no sign of heartbeat or respiration, it's a stillbirth. Okay, and it could be 20 week or before 20 week or after 20 week, just whatever the things, that is the point, that after delivery of the baby. Okay, so abortion question I'll discuss today more question, because I want to be more confident. Even I discuss one topic because every topic is very important. If we one candidate asking me personally, what should be more focused, I said only either more stronger 2 point, either medicine or surgery, or medicine or gynae or pedi, like that way. If you confirm I'm strong enough to correct those questions, it's enough for being passed. This is the tips actually. So pregnancy, for we are the practicing the medicine, but pregnancy is that we can catch those questions easily if we do practice. So first question will be discussed with me, my panel here. Dr. Donilda is here today.
Yes, ma'am.
Dr. Donilda, question 1 is for you. Are you able to talk with me?
Yeah, but I cannot see it. Yeah, 1 minute. Yeah, okay. Pregnant in first trimester, developed vaginal bleeding, LL quadrant pain. She denied any passage of tissue. USG shows no sac, either intrauterine or extrauterine. Diagnosis: it's a missed abortion.
No, dear Donilda, first of all, I want to ensure that she denied, okay, she denied any passage of tissue, all right? But if you see this missed, if you see no bleeding but surface closed, but they didn't give any clue first, okay? Second, first trimester and vaginal bleeding and left lower quadrant pain. So ultrasound finding no sex. So dear, if missed abortion means what? There is a sac, fetal sac or uterine sac there. Okay, but there's nothing. So it is one kind of ectopic, right? Because on ultrasound, no sac either intrauterine or extrauterine, so no sac.
Okay.
So if I say intrauterine or extrauterine, either cervical or ovarian or fallopian tube, but we don't know where the pregnancy located. We don't know.
Okay.
Clear, Dr. Donilda?
Okay. Okay.
So
Yeah.
answer is what? Answer
Ectopic,
is
ovarian ectopic.
ectopic, but pregnancy of unknown
Pregnancy
location. We
of
don't know where,
unknown.
unknown location.
Unknown
Clear? So
location.
this
Okay.
way, those who see why not missed, because there's cervix. Even if we read the ultrasound finding, there's no sac. For
Okay.
missed abortion, there will be the most sac in my uterus. So there is no uterine cavity. So there's nothing. So we have to know, okay, it's a first trimester, but there's no sac means we don't know where is the sac present. Right?
Okay. Okay. Yeah.
Okay.
Thank you.
Clear?
Thank
Thank
you.
you.
Yeah.
Second question will be discussed with me, Dr. Disha.
Hi, ma'am.
Hi.
The
Yeah.
question is pregnancy 7 weeks with vaginal bleeding and no intrauterine or extrauterine sac. Options are ultrasound after 2 days, reassurance, or discharge home. So
Okay.
I think the answer is ultrasound after 2 days.
Because we have to wait, right?
Yeah,
Because we have to wait for the sac. Okay, yeah. For sac presentation, it may delay. Yeah, we have to wait.
We have to wait because it is in the 7th week only, and there is, so we have to wait for 2 days and then we have to confirm. So I think
Confirm, and
ultrasound
we have to do. Yeah, excellent. Again, done. Excellent. Thank you, Dr. Disha. You done
Thank
good.
you.
Yeah.
Thank you, ma'am.
Question 3 will be done by Dr. Ikra. Question 3.
Ma'am.
Yes, ma'am.
Miscarriage in an old lady, 45 years. She asked if her age had anything to do with her miscarriage.
So some doctor, these are the recent recall. Just remember, old lady, 45-year-old lady come to the hospital and history of the miscarriage. Okay, and asking if anything risks for having miscarriage. Dr. Ikra. So
Yes,
age
ma'am.
also a factor. Okay. So what are the percentages for having miscarriage in this older age?
Ma'am, I think it's B, 10 to 50%, 45 years of age.
No. First of all, I will discuss later. First of all, say patient asking age, if her age had anything to do with her miscarriage. So at her age is self causing high risk factor for miscarriage. So it's a 80% chance. Okay. I'll discuss.
Yes.
Okay. I'll discuss.
Okay. Thank you, ma'am.
Question I will discuss today, because this question collection, and we have to remember that how they are asking. Okay. Question 4 by Dr. Hira.
Yes, ma'am. Question 4. Pregnant, suddenly at her mid-second trimester, came to ER complaining of gush of fluid, but plus tissue passed out. What is the diagnosis? Complete abortion, cervical incompetence, incomplete abortion, threatened abortion. Ma'am, it's complete abortion because he has passed the tissues out.
Okay, excellent. Nice. Thank you, Dr. Hira. Thank you. Yeah, you are correct. So question 5 by Dr. Reza.
Yes, ma'am.
Question 5.
Woman with history of miscarriage, no in 7 weeks with vaginal spotting, no history of passing tissue on examination, OS is closed and no bleeding, closed, no bleeding, and vaginal spotting means treated abortion.
So what is your answer?
Treated abortion, option 1.
Okay, so what are the clue here, Dr. Reza?
Because the OS is closed and just the patient have just vaginal spotting.
Okay, excellent. Nice done.
Thank
This
you.
is the
Thank
DHA recall recently. Thank you. And
Thank you, doctor.
actually question we have to remember the Donilla was performed, Dr. Disha nicely performed. These are the some question collection from the recall also. So we have to remember this way. Dr. Reza nicely done. So I practice the question with Dr. Donilla that unknown, we don't know the location of the pregnancy. So see, ovarian ectopic if they give or anyway, we will find out ultrasound that the product of conception in the adnexal mass if ovarian ectopic. Complete abortion, no, because there is expulsion of tissue, there is no clue here. Missed abortion, Dr. Donilla was telling. Non-viable pregnancy is absence of symptoms. So for the missed abortion, there is no symptoms here, so it's not missed abortion. Okay, only bleeding there. So even there is no sex, so it's not missed abortion, non-viable. Pregnancy of unknown location, the answer was Dr. Donilla's question. If the gestational sac cannot be seen, we are not seeing the gestational sac in the uterus, but the presentation fully in pregnancy. So this is the pregnancy of unknown origin. Okay. Another question I was also discussed with Dr. 80% regarding the age-related miscarriage. So see, age-related miscarriage 80% chance of in age 45. So after 45, before 45, like 40. 50% of all cases of early pregnancy loss. 50% of all cases of early pregnancy loss due to fetal chromosomal abnormalities. Most common factor experience early pregnancy loss due to advanced age. Okay. So advanced age is the very important factor for the pregnancy loss. We have to strongly remember this point. So I discussed today more question. I will take more question because this I want to be sure that my candidates are strong enough for exam question. My dear candidates, physiological implantation bleeding when a product of conception implant there is a bleeding, so it doesn't mean threaten, it is not me, so small amount of bleeding there. After fertilization within 10 to 14 days there will be the bleeding, but it is small amount, so there is nothing to be worried. We have to do it, reassure the patient, because this another or indeed way they ask this question. Okay, so question 1, Dr. Saba Jisan, question 1.
Question number 1. Picture of
Yeah.
ultrasound as shown above and patient presents with the minimal bleeding and she denied passage of anything and cervical os is closed. She's pregnant at 8 weeks. Number 1, A, complete abortion. Number 2, threatened abortion. Number 3, missed abortion. And number 4, an embryonic sac.
Embryonic. So Dr. Saba, my question, what you are seeing in the ultrasonography, though we are not sonologists as far as I remember, but I am not, so what you are seeing in sonology, this is the basic. What you are seeing, what is the sonologist? In sonology, what we are seeing, there is either, is there any product of conception or not?
Ma'am, there is products of conception. I think so there is a products of conception present.
This is the blank, dear. This is a blank.
So
If product of conception there will be the like that way. This is the like, this is this way they will give a product of conception like a baby. Okay, there is nothing.
There are 2 images. There is a 2 images. In one there is a product of conception is present, and in other there is nothing. So it is complete abortion.
Okay.
No,
Okay.
ma'am. And the presentation is minimal, and she denies passage of anything. So, ma'am, it is, and OS is also closed. So it is, ma'am, missed abortion.
Okay, I'll discuss this
Ma'am,
question because this is a very important question. I'll discuss. Okay, this question will be discussed with me, Dr.
Ma'am, can I discuss?
Yeah, Dr. Kutsia. Yeah, you unmuted and you tell me. Yeah.
Ma'am, in this picture, there is no sac in ultrasound. So the answer is answer D, an embryonic sac.
Yeah. Another way that this is this is a blank. And Dr. Kusa done nicely that this is a blank. So it's anembryonic. Second, cervix closed and minimal bleeding. So all goes towards, even we are not sonologists, especially my side. So, but if there is a product of conception, even if you do Google, if any baby present, there will be the like a picture product of conception, but there's nothing. So it's a fully blank. So it's an embryonic sac. There is sac present, but there is no fetus. Okay. Dr. Kusia nicely said. Dr. Saba, clear?
Yes, ma'am. It's clear now.
Clear. It's a
Yes, ma'am.
blind and it's an empty sac. There is a sac present, gestational sac there, but there is no product of conception. Okay. Okay. So
Yes, ma'am.
thank you. Yeah. Question 2 is there. Question 2 will be discussed with me. Dr. Sajma.
Yes, ma'am. Pregnant woman at 15 weeks of gestation came with severe bleeding and components seen in cervix. What is the most appropriate next management? IV fluid and misoprostol, IV fluid and expectant management, IV fluid and DNC, IV fluid and uterine massage. The option would be B, IV fluid and expectant management.
So first of all, I'm discussing with Dr. Sajma, right?
Yes, ma'am.
Yeah. Dr. Sajma, see, 15-week gestation, severe bleeding. Okay. And compost or components, I mean fetal seen in the cervix. So Dr. Sajma, see, you're posting on gynae. You are seeing the severe bleeding and on cervix there is a product of conception. What you will do? Just tell me. It's a basic. What you will do?
I will try to maintain the hemodynamic status first because there
Okay.
is severe bleeding.
Done.
Plus,
Okay.
and we'll try to do the measures which minimize the bleeding.
No. It's okay. You done all. But as you are doctor, you are working in the gynecology. There's a product of conception in the cervix. You have to do what? You have to do curettage and dilatation to remove this because already it's come towards the cervix. So you can't continue anything rather than you done expected management, right? If below 13 weeks, medical management. But the thing is that the severe bleeding, you done all hemorrhagic, you done fluid management, everything. But main clue is that we have to do DNC. Okay, main clue is that components seen in the cervix. Okay, Dr. Sajma.
Okay.
Question 4 will be discussed with me. Okay. Before that, question 3 is here. Question 3, Dr. Sneha Raj.
Yes, ma'am.
Yeah, question 3.
19-year-old pregnant did a home pregnancy test 8 weeks back. She came to the clinic to do an examination and they found out that the baby was dead at 5 weeks and she had a black blood clot. Ma'am, so she did a home pregnancy test which was 8 weeks back. So the fetus was dead at 5 weeks. In that case, up to 8 weeks, we can do the expectant management, ma'am. So option 4, expectant management.
So your point what that this is a pregnant and home pregnancy test 8 weeks back and she came to clinic with do an examination. They found what? They found out the baby was dead, right?
Yes, ma'am.
And there is a
At 5
black
weeks.
blood clot. So there is no observation, there is no suction, there is no misoprostol. So we have to
Yes, ma'am.
choose expectant
Expectant.
management.
Yes, ma'am.
Okay, excellent. Only question 5 I will discuss with Dr. Shruti.
Hi, ma'am.
Yeah.
Question number 4. Women at 7 weeks came with abortion. Female denies passage of part of product after doctor examination. Show tissue products in cervix. Clear scenario. What is the management? A. Expected management. B. D&C. C. Progesterone. D. For surgery. Since there is tissue products in the cervix, they have to do D&C now.
Okay, but your question 5, there is no DNC option. So what you will choose here? It's a
Expecting.
expectant management, right?
Yes.
Here?
Okay, ma'am.
Okay. So actually, Dr. Shruti's question, the 7 weeks came with ovulation and female denies a part of product after the doctor examination show tissue product in service. So you see tissue product in service, doctor, I was discussing Dr. Sashma maybe that there's a tissue product, there's a DNC was option. So two question. First of all, Dr. Sashma's question, I want to see. Okay. Severe bleeding and components seen in the cervix. There is the IV fluid and DNC. This was the Dr. Sashma's question, and your question was 7 weeks with female denies, but doctor examination you done, and there's a tissue product service. So actually, expected management means what? Actually, we have to fully manage this question. Dr. Sashma's question, just severe bleeding, cervical component there, we have to choose DNC and expected management. These two questions, if you get in the exam, just remember in option and you have to see in the option. Because if there's a service in tissue products, we have to do DNC. But they are marking expected management. Either they'll give many clue. Vital stability, instability. Like it was husband's question, BP. They didn't mark here any BP, but they'll mark obviously the BP, hemoglobin level, so IV fluid, DNC. Even Dr. Salzman's question B option, IV fluid expected management. Expected management include DNC. But somehow we have to keep our mind both option. We have to read for even somehow DNC will not be on the option, but only DNC option, expected management will not be the option. So both for these two questions, that's why I remark here. These two questions, as these are the recall, these two questions you have to remember that cervical component here means I have to do DNC. But if DNC is not in my option, it's the expected management. Clear, doctors? Dr. Shruti, Dr. Sashma, clear?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
So, question 1. Question 1 by Dr. Somia.
Yes, ma'am. Yes, ma'am.
Yeah. Question 1.
23 years old female, pregnant in her 28th week. Pregnancy test was done at home. She presented with mild bleeding, loss of fetal movement. She denied any passage of tissue or abdominal pain. Transvaginal ultrasound was done and showed the pregnancy of 18 weeks and no heartbeat. No other information was provided about the cervix. What is your diagnosis? A, fetal demise, B, missed abortion, C, incomplete abortion. If currently she is 28 week, but ultrasound shows the 18 weeks fetal. It's
Just a second. And another point is loss of fetal movement, Dr. Dr.
yes,
Sajia, no?
my
Yeah, Somia. Sorry. So Somia say 28 weeks, but fetal in ultrasound presented 18 weeks, so there's no only
but less
mild
than,
bleeding. Main point here, loss of fetal movement.
okay, so it's fetal demise.
Fetal demise means I already discussed that after
It's
fetal
after
demise
20.
and no. I discussed fetal demise Another name is what? Stillbirth.
Stillbirth, stillbirth.
So still is that deliver the baby or not?
No, ma'am. So it's missed abortion.
This is missed abortion. Yeah. Clear?
Yes, ma'am.
Yeah. Question 2 from Dr. Jabir is here.
Yes, ma'am.
Yeah.
Assalamu alaikum, ma'am.
Walaikum salam.
Can I start?
Yeah. Question 2.
Patient at 8 weeks gestation presenting to the ED with vaginal bleeding and abdominal pain. Her cervical os is open and tissue can be seen within the cervical os. What is your diagnosis?
First of you are emergency doctor, patient come with vaginal bleeding and abdominal pain, and you saw there is a os open. Okay,
Yes,
so
ma'am.
os open, there's a bleeding,
And
but
tissue
they
can
didn't
be
give
seen.
any clue regarding the tissue can be see within the os. You can see there's a tissue present. So all goes to, if you remember by excluding method, my tips, what will be the answer?
Is it inevitable abortion, ma'am?
Okay, excellent. Inevitable abortion, first of all, the os is open, right? And there is a fetal os and there's a fetal tissue on the os present. Actually, there is no fetal survivability. There's no chance of fetal any movement or any chance of fetal movement. Okay, so it is a inevitable abortion. Nice done. Yeah, thank you, dear. Nice done. Yeah. Question 3 will be discussed with me, Dr. Badhon.
Yes, ma'am. Assalamu alaikum.
Walaikum salam. Is that visible? Question 3 is visible or not? Okay, Dr. Badhon is here or not? I'm not understanding. So question
Okay,
3
okay.
will be,
Yeah, ma'am. I'm hearing.
okay.
Pregnant in antenatal visit has history of 4 first trimester abortion. What is the highest diagnostic value? Karyotyping, hysteroscopy, hysterosalpingography, and pelvic ultrasonography. 4 first trimester, history of 4 first trimester abortion. Then I will go for
So, Dr.
hysteroscopy.
Badhon, my question is, you are handling a patient and patient telling, ma'am, I have four
First time.
fourth time history of 4 time my first trimester abortion, but fourth time abortion that, but first trimester. Understand? You have to understand the question. So
Yes.
first of all, I am your patient. I'm telling that I have 4 time abortion, but all are first trimester. I said first trimester abortion always goes toward advanced age. It is main point. Advanced age.
Due to the
Okay.
chromosomal aberration. Oh, yeah.
So what is the answer? Chromosomal abnormality I already discussed. So what you will do right now? For the chromosomal abnormality, you karyotyping. Clear? Because first of all, I discussed that advanced age, chromosomal abnormality, all are the related to the advanced age. So highest diagnostic value you have to do karyotyping. Clear?
Karyotyping. Clear, ma'am. Okay, thank you, ma'am.
Welcome. So now another topic regarding the recurrent pregnancy loss is very important. Though just I highlight few points we have to remember regarding the recurrent. Actually, recurrent pregnancy loss for practice, we have to know what are the main patient we have to deal every day, like a patient antiphospholipid syndrome, recurrent pregnancy loss, miscarriage. So other than this misconnected tissue disorder, there is some genetic factor, epidemiological factor we have to remember. So either maternal age, number of previous miscarriage, these are the factors. This is the epidemiological factor. Another antiphospholipid syndrome patient, known case of antiphospholipid syndrome, genetic factor. Okay, genetic factor itself cause miscarriage recurrently. Okay, embryonic or chromosomal abnormality you have to remember. So chromosomal abnormality in embryonic cell you have to remember that is a 57% of chance of having miscarriage. So these are the cause. Somehow they ask by advanced age chromosomal. I discussed with Dr. Badhav karyotyping. This way they ask in the exam. Congenital uterine malformation. Okay, so congenital uterine malformation. This clue, other than though there's lots of this shortly, I want to discuss that congenital uterine malformation. Prevalence of uterine anomaly recurrent miscarriage is 1.108 to 37.6%. Because why I'm marking here? Because this percentage they ask. If uterine anomaly present, what is the recurrence miscarriage chance? So we have to remark it. That's why this is colored. I colored it. This is the recall. It is the chance of having 1.8% to 37.6%. Recommended investigation first trimester miscarriage. We have to do the karyotyping, cytogenic analysis, okay, parental peripheral blood karyotyping, okay. We can do anatomical factor, like a female patient come to my hospital with anatomical factor means what? We can do hysteroscopy, laparoscopy to see the uterine cavity, fallopian tube, is an anomaly present or not, to confirm the diagnosis. If need, we can do hysteroscopy to search for the it's a standard diagnostic value to intrauterine anomaly. So if this question asks for intrauterine abnormalities, what is the definitive test or what is the standard value? We have to do hysteroscopy. So ectopic pregnancy question. Remember that already I discussed with Dr. Donila that the other side of the uterus. So mainly most common location exam question is the fallopian tube. So life threatening, even mom lost the fetus, fallopian, self-injecting, the excellent and must you will. Excellent question. Must you have to face either self-ingostomy, either neither self-injectomy. So anyway, you'll face this question or method exit. We have to give. We'll practice more question today, inshallah. So ectopic pregnancy fallopian tube is the most common location for the ectopic implantation in the world. It's more than 90% chance. But in abdomen, cervix, as I discussed, in ovary, cesarean scar, it can be implanted. Risk factor for having tubal pregnancy is a risk factor for ectopic. Women with history for one previous is another question. One previous ectopic chance of having again a 10%. Risk of ectopic women with history of two or more previous ectopic is chance of having 25%. After I'll give this note after my session, just mark it what I'm telling. Percentage they ask, just blindly remember those percentages. If any way abnormal fallopian tube, if any peritubal adhesion, we after salpingitis, appendicitis, there's adhesion, okay, damage to the fallopian tube, secondary to surgeons, okay, prior to sexually transmitted disease, if any patient has intravenous technology or intravenous respiratory technology used. So these are the factors for having fallopian tube anatomical deformity. Presentation, clinical presentation, ectopic pregnancy, we know very well, though sometimes we do wrong. I will tell shortly regarding the delay menstruation, pain, bleeding, spotting, and there's tenderness and palpitation, bimanual pelvic examination, there will be cervical motion tenderness, this clue they must give in the exam, okay, for the diagnosis, if they say what is the diagnosis. So is that ectopic, is that abortion? So cervical motion tenderness, other than cervical also opening or closed, don't be confused. First of all, see what they are trained, what they are given. So posterior vaginal fornix may bulge. Posterior vaginal fornix may burst from blood in the rectouterine cul-de-sac, or a tender boggy mass may be felt bedside of the uterus. So see, there will be the burst like appears in the vaginal fornix. Even this clue they give in the exam. So it's nice. This clue if you get in the exam, it's ectopic pregnancy. So rupture. Rupture always life-threatening. It's a hypertension due to bleeding, abdominal aortic, there's severe bleeding, okay, there's a pelvic pain, there's sharp stabbing pain, tearing. Do we know? But actually they ask management from the ectopic pregnancy, even they ask from the diagnosis. For the diagnosis, we have to do initially serum beta HCG. Okay. Rapid and accurate manage determine the pregnancy essential. So transvaginal ultrasound we have to do to see the location, either uterine cavity or ectopic site or not. Okay, during adenovital cavity or not. So what is the site, yolk sac appearance? Okay, size according to the weeks, is that coincides or not? Adnexal finding, sonographic result. Okay, visualization of the adnexa. All we have to remember, if fallopian tubes and ovaries are visualized and extrauterine yolk sac embryo, fetus is, you have to identify, and ectopic pregnancy you have to confirm. First of all, initially we do beta HCG, but transvaginal always definitive. We have to check the where it is, the size, along with the gestational sex. So, because before rupture, if it is ectopic, we have to save our patient. Either we'll start the surgical or start the medical management. Okay, so it's a very important definitive is a TVUS, transvaginal ultrasound we have to do for definitive test to see the ectopic site. Now management, very important, must to know, must to know. Today every candidate's homework is strongly remember these slides. Medical management. Methotrexate is the preferred treatment option for the following. When I can give a patient methotrexate? First of all, hemodynamical stability. Second is serum beta HCG concentration below 5,000. One recall, recent DHA recall. One candidate asking me, ma'am, it was 6,000 and there's severe bleeding. But I marked methotrexate. I said why? So they said that initially even they didn't give any clue, life-threatening. But first of all, even severe bleeding or severe abdominal pain, it goes towards what? It goes towards life-threatening. Even severe bleeding not an option. Only severe abdominal pain. It goes towards life-threatening. So 6,000 itself means the sac are enlarging. That's why beta HCG are higher in serum levels. So we have to do immediate surgical, either salpingostomy or salpingectomy. Salpingectomy if vitally unstable, and gostomy if stable. So one remarking point is 5,000. We have to remember, if below 5,000, sac is small size, so beta HCG is not so higher. So you have to start methotrexate medication, and we have to keep follow every weekly. No fetal cardiac activity detected. So we already done the TVUS and there's no fetal activity. So you have to start the methotrexate. Ectopic mass less than, another point. 2 point very important. If it is 5 centimeters, 6 centimeters, it means what? It means it's a higher say. Either you have to do gostomy, means what? Removal of the conceptus product from the fallopian tube. And jectomy means what? You have to cut down the fallopian tube. So if ectopic mass only below 4 centimeters means 2 centimeters, 3 centimeters, we can start the methotrexate. Patients are willing and able to comply with post-treatment follow-up. So patients are telling, ma'am, I can take your follow-up every day, no issue, and I can take an emergency service. So actually it's my wish. I am not willing to do any surgical procedure. I want to take medication. Any time of being reasonable, I can got admitted, I will understand my presentation like that way. It's a patient wish. Okay, so this is the another way. Absolute contraindication for myself, just see one time. It's not so highly recommended. Just remember, when we can't give methotrexate, we have to remember methotrexate contraindication. Absolute, this enough. We have to remember intrauterine pregnancy. Another is if active pulmonary disease means what? Active pulmonary disease means a patient in exacerbation of asthma, COPD, and infective active setting. Active peptides, though it's not so high yield point, but just for understanding, even if you practice, remember that we can't give methotrexate. But a patient, a POD patient, active POD, peptic ulcer disease, you have to avoid methotrexate medication. So moderate to severe anemia, leukemia, rupture ectopic pregnancy, hemodynamic unstable patient, we can give this methotrexate medication. This dose just it's my tips though this I given large chart. Shortly I want to say 1 or 2 points. What is that? First, I will start the methotrexate medication, single dose. Okay, it's a 50 milligram first, and I will check beta hCG level within 4 and 7 days. Actually, weekly we see 7 days. Just remember, if it is decreased more than 15%, it's a good. Weekly, I have to follow up this patient till undetectable result of the beta hCG. Okay, so 50% if decrease greater than 50%, so it means my medication are responding and it is working. So I have to keep follow up till it is undetectable beta hCG. But if it is not decrease, it's less than 50%, we have to start randomized methotrexate dose, or we have to intramuscularly repeat. Means if it is single as 50, we have to repeat this, we have to increase the dose or repeat the dose. Okay, anyway, we have to increase the dose, the methotrexate level, readmit. First of readmit the methotrexate or intramuscularly do and repeat the hCG again 7 days after. We have to keep follow up. If it is not decreasing, it means I have to keep on surgical management. 2 dose regimen, actually it goes towards the patient presentation. SAC 4 centimeter, beta hCG 5000. We can start second dose or repeated dose intramuscularly than orally. But the thing is that 1 point, this second dose, third dose, fifth multiple dose, this is not my exam theoretical knowledge. My exam point is 15% decrease or not. If 50% decrease, we have to keep follow up till undetectable. If it is not decrease, we will repeat or we will increase the methotrexate dose, and we have to keep follow up. If it is still not decreasing, so surgical management is a sulfingostomy. These are the summary. For full chart, just remember same this way what I said. This if it is below 50%, above 50%, what we do, repeated the management, repeat the increase the dose of methotrexate. That's it. That they this way they discuss. So if beta hCG plateau increasing during follow up, so we have to we are administrating the methotrexate, but persistently if it is increasing, that means we have to go towards the surgical management. Okay, so surgical management is the sulfingostomy or jectomy if it is failure to the medical treatment. So first of all, serum beta hCG determination weekly we have to do. Weekly I discuss, we have to do weekly determination. Second, beta hCG level plateau or rise, fail to decrease adequately by 15%. So when we have to we have to announce that it is medical treatment failed if it is not decreasing. Now surgical management, surgical indication when we have to do the sulfingectomy if it is hemodynamically instability, rupture ectopic mass. Okay, so this is the contraindication, you can't give methotrexate. Okay, sulfingostomy indication, remember, if vital is stable and medical management are failing, we can just remove the product of conception. It's a sulfingostomy. So remember that preservation of the tube for potential features. So if I can able to preserve the tube means what? Jectomy means I already cut down the tube, so the fertility rate decrease. Our aim is to improve or to ensure fertility in the future. So gostomy always best rather than jectomy. So gostomy prefer if desired future childbearing age is an early child, okay, and if there is no damage in the tube, so all goes towards the sulfingostomy. And sulfingectomy always you have to remember that if patient even complicated case, childbearing, but we always have to remember that jectomy always in the life-threatening case or persistent trophoblast means we removed in persistent trophoblast is the characteristic that we remove the product of conception but still beta HCG higher. So it's a persistent trophoblast. So in this case, we have to do self-injectomy. So these are the criteria. Just remember those way the criteria he had written. Laparoscopy, self-injectomy, just removal of the all part of the fallopian tube, or ghostomy, just removal of the only affected part. If laparotomy, if we have to do if large amount of bleeding, okay, this way we have to do management. Persistent trophoblastic criteria, already discussed that shortly. I said that persistent trophoblastic characteristic that bleeding, already incomplete removal of trophoblastic and still beta HCG higher the level. So in this case, we have to do surgical intervention. So after surgery, beta HCG level is really not fallen down. Okay, 10 to 15 minutes easily fallen down, but it is not fallen down. So you have to take decision regarding the self-injectomy. Follow up after treatment, as I said that weekly you have to follow up till beta HCG undetectable. So now practicing. This question will be started by Ifada, Dr. Ifada.
Yes, ma'am. 40 years old male, pivot with history of tubal ligation 4 years ago after her last CS delivery. Her last menstrual period was 6 weeks ago. Presented to ER with vaginal spotting, no abdominal pain, OA os is closed, tenderness and fullness in her abdomen in right lower quadrants. What is the best initial investigation? A. Pregnancy test. B. Ultrasonography. C. CT abdomen. So the best initial investigation is pregnancy test because the menstrual period was 6 weeks ago and 40-year-old female with a childbearing age.
But Dr. Ifada, what about that already done tubal ligation? This question frequent, as far as I remember, I'd given this question a mock, and frequently I face question just for understanding why pregnancy test, why not ultrasound? Dr. Ifada.
Yes, ma'am. For the ultrasonography?
No. Dr. Ifada, don't be confused. First of all, I discuss that why pregnancy test, why not ultrasound? Though tubal ligation done 4 years back, I want to know why and why not. A and B. This question, actually you answer correct, we have to do pregnancy test, and I already discussed this question many times in the groups, and many question was why it's still sterilization done, tubal ligation done, so how pregnancy test, and already 40 year. Anyone can tell me? Dr. Kishori? Somia.
Yeah, ma'am. I'm here, ma'am.
Okay,
Ma'am,
why?
Some research says that about, I don't know the percentage, but after doing tubal ligations, there is a chances of ectopic pregnancy, even though even though the tubal sterilization is failed, but also the like a rate of ectopic pregnancy is increases in such kind of cases.
Yeah.
That's it, ma'am. I know.
Okay. Yeah. Dr. Kishori's point that though tubal ligation done, there is chance of having ectopic pregnancy. First of all, Dr. Kishori says the percent is not fact. The thing is that chance of having pregnancy even though tubal ligation. It is the point. Okay. So many candidates asking 40-year tubal ligation that, but even though there is chance of tubal ligation failure, it is the point we have to remember. Many candidates mark ultrasound because why? To see the from the bleeding side, to see the anatomical side, any other pathology there or not, endometriosis or not. So no. First of all, they said the doctor. It's the doctor. This question was this is Dr. Ifada maybe. This question I was discussing that 6 weeks ago there is a menstruation period off. So last menstruation 6 weeks back. So menstruation off. It is not endometriosis. So we don't need to remember regarding the ultrasound. We have to do the pregnancy just initially to ensure is she pregnant or not. Okay. Second question clear?
Yes, ma'am. Clear, ma'am.
Yeah. Okay. Though you know the answer, but actually explanation I need. Because why this is the answer? Because you have to even if you itself you have to remember that okay, chance of having pregnancy even though tubal ligation failure rate is high. Second question will be discussed with me, Dr. Moushumi.
Yes, ma'am.
Yeah.
Case of ectopic pregnancy which is method
Actually,
or
your
beta
voice may be not clear. Hmm?
now it's clear.
Yeah, now clear. But best it to high just high raise the voice volume.
Case of ectopic pregnancy which is method or beta HCG wire on day 1 3000, on day 4 3100, on day 7 হচ্ছে 2900. What to do next? Nothing, surgery, multi-dose methotrexate regimen, consider second dose of methotrexate. Consider second dose of methotrexate because there is less than 15% of decrease in beta HCG level.
So it's a second dose of methotrexate, right?
Yes, ma'am.
Okay. Thank you, Dr. Moushumi. It is the second dose of methotrexate. Thank you. You're done good. So third question will be from Dr. Priscilla Pushpam.
Yes, ma'am. Patient with ectopic pregnancy. Her husband is in a military mission. She lives 80 kilometers away from hospital. Brought by her neighbor, ultrasound showed unviable fetus, absent heartbeat, 4 cm fetus, beta HCG is 5,000. What is the indication for surgical intervention? A, beta HCG, B, fetal heart, C, fetal size, D, far away from hospital distance. D, far away from hospital distance because she cannot come for follow-up if we give her methotrexate.
Okay, excellent. First of all, we have to remember the patient condition that ultrasound show unviable fetus, right? And absence heart rate, right? And beta C HCG is
Yes, ma'am.
5,000. So we have to choose what? We have to choose that surgical intervention must needed because all our goes towards the ectopic pregnancy. It could be the life-threatening later, but it's still not that it goes towards the life-threatening. But the all march towards the life-threatening. It goes towards it can anytime can start the bleeding, anytime can cause any unviable pregnancy, and any kind of the life-threatening situation. So we have to first do intervention because this is the far away from the hospital or distance. That is the way, and we have to choose it. This is the recent exam question. Okay, Dr. Pushpam, thank you. This you done very well.
Thank you.
So Dr. Moushumi done that the second dose of methotrexate we have to increase that it is not decreasing more than 15%. So we have to correct and increase the dose. So this way we have to think. And tubal sterilization, that the first question Approximately 30% of pregnancy that follow a failed that sterilization. 30% pregnancy tubal sterilization. Dr. Kishori was discussing with me that failed tubalization. 30% chance for having ectopic. Okay, it could be the 20% even postpartum procedure. Okay, so this way we have to remember. So this question will be discussed with me, doctor. If Nipuni able to talk or not.
Yes, ma'am.
First question.
Is it question number 4, right?
Yeah.
A female patient diagnosed as ectopic pregnancy where she lives far away from the hospital. Her beta HCG level is 6,000 with an absent fetal heartbeat. What is the best management for her? First, methotrexate, B, surgical intervention, C, expectant management. Ma'am, it's B, surgical intervention.
First of all, is this a clue? What is the main clue here?
Her beta HCG level is 6,000 and
6,000.
fetal heartbeat.
Absent heartbeat, okay, fine. We can start methotrexate, but we are not starting methotrexate because why?
She
Lives far away. 1 point, lives far away. Second point is beta HCG 6,000. Right?
Yes.
Nipuni.
Yes, ma'am.
Okay?
Yes, ma'am.
Yeah. Thank you.
Thank you, ma'am.
Thank you. Question 5 by Dr. Priya. Dr. Priya is here.
Yes, ma'am.
Yeah.
Female patient present in the emergency with lower abdominal pain and bleeding. Ultrasound done and a 3 centimeter ectopic pregnancy found in the ovaries. The beta HCG was 15,000. From the above history, what will make the medical treatment contraindicated? Option A, the size, B, the abdominal pain, and C is the beta HCG level. Ma'am, the question meaning is from the above history, what is why the medical treatment will be contraindicated in this patient, right, ma'am?
Yes. What is the cause by reading? You already read the question. Is there any clue that you can't do medical management? You can't give methotrexate. Methotrexate contraindication.
And the beta HCG value is 15,000, ma'am.
It is more than 5,000. It's 3 times higher.
3 times higher, yes, ma'am.
Even size is 3 centimeters. So what the size is not acceptable? Below 5 centimeter is acceptable. So, but here 3 centimeters is okay. We can accept it. But beta HCG level is not. But beta HCG, if it is size 6 centimeter, even it is contraindicated. Right? And beta HCG level 15,000 is the contraindication. So, this is the contraindication. Yeah. Thank you.
Thank you, ma'am. Thank you.
Yeah. Question 7. By Dr. Kishori.
Okay. A female patient, her LMP was 6 weeks ago, presented with mild abdominal pain, vital stable, closed os. Ultrasound showed no intrauterine pregnancy, but a 3 centimeter sac in the fornix area with no cardiac activity. Beta HCG was 3,000. What is your management? Okay, ma'am. A, medical management, it's not possible because 3,000. Surgical management, no, medical and surgical. Medical management, given that she has access to the hospital. Is C, ma'am? Actually, A is also correct, ma'am. Medical, if, ma'am,
First of all, Dr. Dr. Kishori,
okay.
When you read the question, first of all, you tell me, ma'am, this sort of information.
Okay.
I am
Okay,
thinking, this way.
Ma'am, though she is vitally stable. She is vitally stable. And her beta HCG is 3,000.
Means what? It is below 5,000.
If
right?
it is more than 5,000, we go for surgical.
Then we can do, but it is below 5,000.
5,000,
right, Dr. Kishori?
Yes. Yes, ma'am.
Okay.
So the management could be medical.
No,
it
not
could be
could be. It's a definitely. You have to say definitely,
okay,
ma'am,
ma'am.
because only three
The definitive,
sack is three. Yeah.
ma'am,
You
definitive
say.
management is medical, but there are two options. So I would go with D.
No,
Because there is
medical
no cardiac.
management given she has access. No, actually, regarding the D option, first of all, regarding the D option, that she has access to the hospital, it is nice. Yeah, answer actually D. But the thing is that when I have to choose medical management, when I have to choose, she has access to the hospital. If it is not access to the hospital, so I have to do what? I have to do admission for key follow-up, whatever the beta HCG, right? For the
Yes, ma'am.
expectant management. So
Yes.
as they are strongly, they said that vital stable and ultrasound, there's no uterine pregnancy, only 3 centimeter sac, okay, and there's no cardiac activity. So if we have to start medical management, if she has access to the hospital, we have to ensure it, we have to confirm it that is it access to the hospital or not, right, Dr. Kishori?
Yes, ma'am.
Yeah, nicely done. Yeah, answer is D. Actually, regarding the access to the hospital, many candidates are not understanding. Actually, we have to ensure it that if it is not access, if it is sudden patient collapse, sudden patient vitally unstable, it will be the life-threatening the patient. So you have to keep ensure whatever the hospital settings regarding the site. Thank you, Dr. Kishori. Nice done. Question 8 will be done by Dr. Solomon. If Dr. Solomon is here.
Okay, ectopic pregnancy treated sapingo follow-up and beta ACG was decreased until the last 3 visits. The beta ACG result K2. Then beta ACG was 3,200 on the last visit. Normal is less than 5,000. What would you manage? What would you manage the case? A, consider giving methotrexate. Start OCP. C, surgical intervention. D, reassurance. I can't reassure this patient in this case. Now, looking at the information here is that she once had a sapingostomy following an ectopic pregnancy. While she was coming for a beta ECG, it was decreasing. But on her last visit, it's slightly, I think the last visit was 3,200, which is still less than 5,000. So in this case, I think personally, I will consider giving her medical management, which is methotrexate.
Yeah, excellent. Dr. Solomon done excellent. Dr. Solomon, do you know the diagnosis? I feel when I discussed this question, you were not in the platform. Do you know the diagnosis? You done salpingostomy and still beta HCG not decreasing. What is the diagnosis, Dr. Solomon?
I don't know, but I think it's
okay.
still,
you missed maybe, but you have to remember that actually you done. You see, salpingostomy done. You remove the product of consumption, but still beta HCG not lowering. So what does it mean? You must, after a surgical intervention, the beta HCG will be the lowering down, but it is not. So anyone can tell the diagnosis? What is the diagnosis?
Persistent
Pregnancy of
trophoblastic.
unknown location.
No. What was the diagnosis? I was discussed shortly. That if beta HCG
Trophoblastic tissue.
trophoblastic, who was telling? That was
So,
Somia maybe. It's a trophoblastic. It is a Dr. Solomon. It's a trophoblastic. Okay. So persistent trophoblast. You already removed the product of conception, but trophoblastic tissue are there. So beta HCG are not lowering down. So it's a persistent trophoblast. It's a trophoblastic criteria. So incomplete removal of the trophoblast, in which goes towards the beta HCG not settling down. So you have to start the methodology. But if it is more than beta HCG, as we hope, so we have to do surgical intervention, salpingectomy. If it is, there's a rupture or bleeding tendency, right, Dr. Solomon?
Yes, ma'am. Thank you, ma'am.
Okay, thank you. Question was not easy. Just I discussed with Dr. Solomon. I said done. Question 9. It's a Mohammad Umar Shahajad.
Yes, ma'am.
Yeah.
A 34 years old lady, pregnant, complaining of amenorrhea, bleeding, and abdominal pain. Beta-HCG then showed levels of 1600. She was given
6,000,
methotrexate.
not 100. Okay. Also, first is 1600. Okay. Next. Yeah.
She was given methotrexate. 1 week later, she still had severe abdominal pain despite analgesia. Beta-HCG then showed 6,000 units. What is the best management?
Easy
Uh,
question. Very easy question.
Surgical intervention, and
Yeah.
we
So,
will go for the salpingoscopy. Option A.
first of all, Dr. Omer, amenorrhea bleeding. Patient comes to hospital with bleeding, right? And abdominal pain. So this criteria goes towards what? Is that patient stable or not? Which goes towards where? 6,000. Is that patient stable or not? Severe, I discussed shortly right now the severe abdominal pain. This is life-threatening or
Patient is
not?
unstable.
It's life-threatening. It goes
Yes.
towards anytime severe bleeding with shock, anytime. So what do you have to do right now?
Ma'am, it's D, exploratory laparoscopy.
No, still this information they didn't give, that unstable rupture. Just I say, Dr. Umar, try to understand this question that beta-HCG 6,000, severe abdominal pain. Okay, this patient is still stable, but it is life-threatening on way, so on the road. So we have to keep initially by doing salpingectomy. If we do so, it will not be life-threatening. It is not exploratory laparotomy because vitally in details BP, blood pressure, the rupture condition they didn't give first of all. Second, only one who they give severe abdominal pain which goes towards the life-threatening. So we can't wait. Immediately we have to ready the OT and we have to call the specialist for the gynecologist. So for the doing salping, even we can't do salpingostomy because it is not goes to the gostomy because if severe bleeding. So no chance of doing salpingostomy. Dr. Umer, clear?
Okay, ma'am. Yes.
This is salpingectomy. Easy question. Easy question will be discussed with me, Dr. It's a Dr. Fatima. To Fatima, anyone can raise the hand.
Yes, ma'am.
Yeah.
A female 25 years old presented to the ED with vaginal bleeding, nausea, and right lower abdominal pain and tenderness. History of open appendicectomy due to perforated appendix. Her BP 90/50, heart rate 120, respiratory rate 25. What is the diagnosis? A, ectopic pregnancy. B, ovarian torsion, torsion. C, hemorrhagic cyst, and D, abscess. The case is with vaginal bleeding and lower abdominal pain, and there is a history of appendicectomy due to perforated appendix, and this will be the ectopic pregnancy.
So, what is your diagnosis?
Yeah, ectopic pregnancy.
What are the clue here for having ectopic pregnancy?
There is
abdominal pain and tenderness.
Yeah, these are the clue for diagnosis of the ectopic pregnancy. Nicely done, Dr. Fatima. So this way you have to do evaluation. Thank you, Dr. Fatima, that there is a first of all we have to remember what are they said, the criteria, the clinical criteria. Patient 25 years in emergency vaginal bleeding, right lower abdominal pain, tenderness, but history of open appendicectomy. These are the clue, but why I discuss this question? Peritubal adhesion. History of any kind of surgery like appendicitis, salpingitis, endometriosis, this cause adhesion. This adhesion goes towards ectopic pregnancy. Okay, so it can be ruptured any time, but the severe abdominal pain, severe pelvic pain, tachycardia, hypertension, these are the rupture criteria. But this question they just justify you that though they give many clue, but history of open appendicectomy, if they ask what is the cause for having ectopic pregnancy, so due to the peritubial adhesion, history of the appendicectomy before, so it is causes adhesion. Okay. Ectopic vaginitis question, actually, though rarely they give, just remember shortly, ectopic vaginitis question they give after menopausal stage due to atrophied. Okay, so urinary manifestation like dysuria, incontinence, nocturia, these are the urinary manifestation, but vaginal atrophy when occurs is dyspareunia, vaginal itching, this dryness. So we already discussed regarding the tropical estrogen. This management either they ask or they ask the diagnosis. First of all, strong point is the menopausal status. Okay, so local estrogen, one can ask me personally, why not hormonal replacement therapy? No, we have to mark local estrogen initially. Okay, just confirm it. Transdermal estradiol or progesterone patches we can give later, but first local estrogen to moisturize or to itself cause it remove the dryness, this dyspareunia, itchiness. Okay, this way. Cancer screening program, shortly I want to discuss, though screening program file I already uploaded. They asked regarding the breast cancer, I discussed in the surgery portion of the breast, when we have to start, regarding the mammography, when you have to start the ultrasonography, just read the PDF, okay, regarding the breast in details. Cervical cancer always after 21. If a female patient got married in 19 year, we have to start pap smear from the 21, 3 yearly, if there's no high risk factor. Okay. Then regarding the colorectal cancer, it's a, if family history positive, we can start colonoscopy screening from the 45, but if it is not, after 55. Okay. Preeclampsia is a pregnancy related complication. Shortly, I want to tell 2 to 3 words that though we know very well that there is no seizure, but hypertension, proteinuria more than 0.3 gram per 24 hour. Preeclampsia easily occur after 20 weeks of gestation. So risk factor, the first pregnancy, pregnancy teens, women over 40 years. So these are the risk factor for having preeclampsia. And eclampsia, we know very well that there will be the seizure must. So the seizure along the high blood pressure. Okay. Magnesium sulfate to prevent the seizure. Okay. So immediately you have to do delivery the baby. It's another management for decrease the eclampsia. Health syndrome we know very well. Hemolysis, they ask elevated liver enzyme, low platelet. So we have to remember regarding the health syndrome, treatment is the delivery of the baby. Health syndrome, delivery of the baby, along with if seizure, we have to give magnesium sulfate. This very important question I want to discuss shortly, very important exam question, then I will discuss more. Because must read, and you will face in the exam. So we have to remember this question. This question will be discussed with me, Dr. Just for discussion. Dr. Monia Jaman is here. Maha Umer.
Yes, ma'am. I'm here.
Example 1, very important exam question. Though I didn't give any option, just you have to discuss with me what is the diagnosis and how you have to manage.
A pregnant woman in her 30 weeks of pregnancy develops sudden severe acute abdominal pain and is taken for emergency C-section. Her BP 110/60, labs hemoglobin 101, 10.1, WBC 9.5, platelets 65, PT 28 second, PT APTT 67 second, fibrinogen 0.7 low, and bilirubin 23. Ma'am, the diagnosis is DIC, disseminated intravascular coagulation, because platelets are low, PT and APTT high, fibrinogen low, and this all the clues goes toward DIC.
Excellent. So DIC management is what?
DIC management, ma'am, we have to give FFPs, ma'am.
This is 35 week. 35 week DIC develop. What is your plan? Is still fetal movement present? What you have to do for the management of the DIC? Just tell me that we have to do cesarean section. We can't do vaginal delivery, right? First of all, we have to ensure if the fetal growth okay. We have to give the steroid. We have to manage the DIC management. Okay, that FFP if there is a bleeding, rather than no need. If there is a bleeding, so low platelet is only 65. So you have to remember if there is a bleeding. So accordingly, so DIC. Thank you, doctor. DIC regarding high PT, APTT, very clean cut exam scenario. We have to remember, just you go the exam room and you'll get this question. Just remember DIC question, high PT, APTT, low platelet, okay. Regarding the FFP, platelet management, you have to see the platelet, the bleeding changes will be there. And if fetal development is not only 35 weeks, patient on the labor, ensure we have to do actually CS, but steroid. Ensure steroid to premature lung, then we can do delivery by CS section. So DIC trigger factor is the sepsis, surgery, major trauma, cancer, complication of the pregnancy, and even though if there's abruption placenta, it itself cause DIC. Okay. So this question we can discuss shortly. Though discuss means we can. Dr. Jabir. Dr. Jabir.
Ma'am, can I ask a question?
Sure.
When we give the steroid, ma'am, is there
Steroid started if any premature labor, but it doesn't mean we can do delivery. Like premature labor started but only 34 weeks, so we have to ensure the fetal lung maturity. We can't ensure fetal lung maturity. We can postpone this labor and contraction by medication, but first of all, premature labor, we can go through if it is the cause. Why premature labor? Is that placental abruptio, placental previa? Is there any pathology? So according to the management from premature rupture of membrane, so antibiotic we have to give. So we have to settle the patient by giving the painkiller. Okay, and steroid till 37 weeks we have to continue the patient strict bed rest. So if after 37 weeks still labor ongoing, we have to do cesarean section. Okay.
Yes, ma'am. Thank you, ma'am.
Clear?
Yes, ma'am.
Before 34 weeks, if any labor condition, we have to ensure what is the cause and according to the steroid first.
Yes, ma'am. Thank you, ma'am.
Yeah. Welcome. Question example 2 will be discussed with me, Dr. Two Fatima was here. One Fatima discussed, another Fatima remain. Okay. Monia Jaman is not here, right? Okay. First of all, this question, easy question, just for discussion, one word. This question, Dr. Kishori, just read the question and
I'm
tell me
here.
the
Okay.
causology. Yeah.
Okay, I'm here. A 32-year-old pregnant lady at her 38 weeks of gestation presents feeling unwell with sudden onset epigastric pain associated with nausea and vomiting. Her temperature is 36.8. Her blood pressure is 150 and diastole is 100. Her lab shows raised liver enzyme. Hemoglobin is 8.6, that is low. WBC is 5 normal. Platelets is 90. Okay, ma'am. The platelet level is 90. This is HELLP syndrome, ma'am. The indication is low platelet count.
Okay. Another, that HELP, what do you find? Hemolysis. Hemoglobin low already.
Liver,
Hemolysis.
yes.
Hemoglobin also low, right?
Low.
So there's a
Yes, ma'am.
hemolysis. This is the explanation, that hemoglobin low, hemolysis ongoing, platelet low,
Liver enzyme
thrombocytopenia,
high.
liver enzyme high. So all goes towards
HELLP syndrome.
HELP syndrome. These are the criteria, clinical scenario exam. So it is the HELP syndrome management is the delivery of the baby. Okay. Thank you, Dr. Kishori.
Okay, ma'am. Welcome.
Endometriosis is very important. Endometriosis, adenomyosis must we have to face in the exam. Okay. So regarding the endometriosis, my dear candidates, listen very carefully. Patient must come with chronic pelvic pain, with dysmenorrhea, deep dyspareunia. So dysmenorrhea, deep dyspareunia. So endometriosis is a common condition characterized by growth ectopic endometrial tissue. Another segment is endometrial tissue stay in the uterine cavity but outside the uterine cavity. So when it stay outside the uterine cavity, it causes endometriosis. Okay, so endometriosis causes subfertility. Okay, non-gynecologic urinary symptoms, dysuria, urgency, hematuria, dyschezia, these are the non-gynecological presentation, but laparoscopy is the gold standard. Management is the NSAIDs and paracetamol for the pain relief first line, but main management or definitive management is hormonal replacement therapy, trial of the oral combined contraceptive pill. It is a trial. Okay, so just for discussion example, this one, regarding this management, this question will be discussed with me, Dr. Ikra.
Yes, ma'am. A 40-year-old lady presents with painful periods. The pain is worse on the first day of cycle and continues for fifth day. She has regular 28-day cycles. She is sterilized. She had a laparoscopic tubal sterilization in the past.
And she is sexually active. Okay, she is sexually active and you given NSAIDs and paracetamol, Dr. Ikra.
Yes, ma'am.
So you given NSAID and paracetamol for relief, but for few days also complaining of pelvic pain. What
So,
you will give right now? What is the management?
OCPs.
OCP. So we have to give the OCP because that we already given the painkiller NSAID, paracetamol, still persistent pelvic pain. So we have to give OCP and definitive diagnosis by
laparoscopy.
We have to laparoscopy. We have to do definitive diagnosis by laparoscopy. Excellent done, doctor. Thank you, Dr. Ikra. So pelvic inflammatory disease is also very nice exam topic. Just remember that it's the infection or inflammation of the pelvic organ, uterus, fallopian tube, ovaries surrounding peritoneum. But what we have to remember that pelvic inflammatory disease, they give scenario and they ask the diagnosis. As far I remember, one question, cervicitis and pelvic inflammation, many candidates do mismatch. So remember, pelvic inflammatory disease, many candidates ask me, there is cervical excitation, but cervical tenderness Another point regarding the cervicitis that when cervical tenderness in cervical ectropion point, this tenderness only for the cervicitis. So dysuria, menstrual irregularity, vaginal discharge. Another kind is telling me, ma'am, this discharge is not for the cervicitis. Actually, cervicitis is the infection. But we have to remember this lower abdominal or pelvic pain along with the perineum all goes towards the pelvic inflammation. It's a chronic disease. Cervicitis presentation is the acute onset or sudden onset. So we have to do the differentiation. Is it cervicitis or is it PID? So PID positive organism will be the sexually active patient, or Neisseria gonorrhea, chlamydia trachomatis, the presentation will be vaginal discharge, cervical excitation will be positive. Investigation, we have to do the in vitro and the multiple. If the investigation actually we have to screen the chlamydia and gonorrhea, but if there is a sexual pattern multiple present, so it is a very high risk factor for having PID. Below risk factors are below 25. If there is intrauterine device user, new multiple sexual partner, okay, intramuscular and intrauterine device if uses, so infertility, subfertility, tubal, even it causes tubal abscess, tubal ovarian abscess, ectopic pregnancy is a complication. For the complications, see, tubal ovarian abscess, another way they ask tubal ovarian abscess, this topics they ask by how. Only just remember there's an abdominal pain tenderness, but there will be the high fever. So tubal ovarian abscess, there will be no discharge. These 2 points just remember. Tubal ovarian abscess, if left untreated, it goes towards the, if ineffective treatment if you do, so it goes towards the abscess and suspected. Hello. So just mute the mic. So if female present with lower abdominal pain, tenderness, high fever, no discharge, so it goes towards the abscess. Additional, his patient sexually active and doesn't have any barrier, so all goes towards the, actually it's the chronic PID, which is the complicated by tubal ovarian abscess. If it stay remain ineffective treatment, it develops this abscess. Management of PID according to the guideline, we have to remember regarding if it is organism cervicitis, antibiotic we have to give neither the cervicitis. You see chlamydia, if it is positive, so doxycycline. This way they ask clean card. It's chlamydia, so doxycycline. If it is Neisseria gonorrhea, it's ceftriaxone. Okay, and PID outpatient management, OM or MO means what? It's ofloxacin and metronidazole. Okay, inpatient management is we have to remember this ceftriaxone management. Endometriosis, I already discussed this 5Ds point. We have to remember strongly. Very important endometriosis point for the exam. Urinary incontinence, very high topics for the exam. Though it's a surgical part, I already discussed. I must discuss in the surgery, but shortly, they give commonly mixed type stress incontinence. So stress incontinence, urge incontinence, remember, stress means sneezing, coughing related, but pelvic floor exercise we have to give. And if not, surgery is not possible, deloxity. This is a paid exam question. Just you go and you'll find a question from the incontinence. Though Dr. Vizin will share recent recall today, his exam very nice, mashallah. Just take time for arranging the recall. Urge incontinence, leakage of urine, sensation of need it to voice. So urge, I'm feeling pee, but the thing is that I have to go and pee. But the thing is, urge increase before that they can't wait. So detrusal muscle overactivity. So bladder training and antimuscarinic medication we have to prescribe. Okay. So today, urinary incontinence in detail I discuss in the surgery part. So today gynecology session, what I touched ectopic pregnancy, management of the abortion must just keep on eye when method is it, when self-injectomy, when self-ingostomy, endometriosis criteria, 5D criteria, and how we manage just it. And regarding the, I already discussed the PID, this chlamydia, gonorrhea, screening, if APD management, OPT management, how we manage, we have to remember this way. And stress incontinence in an urge incontinence mixed type, I will post the chart, easy to remember those chart, it will be more easy. So thank you, my dear candidates. I'm ending my session. Next session in the Thursday. Thank you, my dear candidates.
Thank you, ma'am. Thank you.
Thank you, ma'am.
Assalamualaikum. Yeah.
Thank you.
Thank you,
Thank
ma'am.
you, ma'am.
Welcome.